So this is our feature presentation. It says, please introduce yourself. I think we've achieved that. It's my pleasure to facilitate our feature presentation using data to identify and deliver on opportunities and outcomes, which will provide information on data resources that deliver timely information to many organizations. We have presentations from each speaker, and then we're going to open things up to the audience for questions. And I was reminded during the break, and I'll remind you again, if you can pause a little bit, so when you're doing questions, pause a little bit and wait for the mic, because we're recording this, and your grandchildren won't know what your question was if you don't have the microphone. So I'm going to briefly introduce each of our speakers, and if you're really curious, I have longer versions of the introductions that you can stop me in the hallway and ask for the longer version, which I'm not going to read because we really want to make space for them. So working from left to right, and that's not a political statement, Jonas Farnham is our first speaker. Over the past 10 years, Jonas has led accountable care organization design, strategic planning, and innovation initiatives, value-based delivery model creation and operations, and statewide population health organization development. He's assisted in creating more than 20 ACOs, community-based delivery organization models, and clinically integrated networks, and has led all the facets of clinical integrated network and value-based operation. At Health Catalyst, he leads organizations on creating sustainable short and long-term population health successes. To Jonas's right is Erica Vanderwall. Erica has worked at the Office of Mental Health Psyches implementation team since 2010. In her current role as Psyches Medical Informatics Project Director, she interfaces between users of Psyches application and Psyches IT development staff to incorporate enhancements, new features, and new data sources to the Psyches application. So we're going to hear about Psyches. To her right is Michaela Ferrari. Michaela brings a diverse set of public health experiences to her role as community engagement manager at Unite Us, which includes conducting evaluations and redesign of public insurance programs at UCLA's Center for Health Policy Research, coordinating as the Turnaway study at UCSF ANSWER Research Program. It's an acronym that you can't really pronounce, can you? Maybe Michaela's going to teach us about. What is it?
Just answer.
Answer. But there are different letters in it.
It's tricky.
Remember, I'm the guy who used to work at ONC on HIT. And sometimes people would call it on shit. Doesn't count. For the record, I'm being monitored to see if I swear, and that does not count yet. So
It's CHIT.
Yes, on shit. The Office of the National Coordinator for Health Information Technology. Michaela has a bachelor's degree from Oberlin College and a master's in public health from UC Berkeley. Next in line is John Paul J.P. Perez, trained as a marriage and family therapist. John Paul Perez has a passion for building strong communities that address the social determinants of health and lift people out of poverty. He's dedicated 20 years to not-for-profit work, managing over 30 programs encompassing over 50 private city, county, state, and federal funders. In 2017, he received his second master's degree from University of Rochester Simon Business School. And finally, Mark McKinney's boss, Tavia Rauch. Tavia leads Hixny's population health and strategic initiatives. Her team is responsible for the implementation and adoption of Hixny's population health solutions, the execution of data quality initiatives, and the management of population health grants to support the organization's continued improvement and relevance. Her experience includes serving as a respiratory therapist with the U.S. Army Reserves, managing grants for New York State Department of Health, and positions in clinical informatics and operations management, and has extensive experience at Albany Medical Center and their rival St. Peter's Health Partners. I still haven't sworn. We'll have two staff with microphones at the end, and now I'll pass it on to Jonas for the beginning of our presentations.
Thanks, Jacob. And can we advance the slides?
The technology for that.
There you are. There is technology. Jacob, I've never had the pleasure of not having to make an introductory joke as I start a presentation. So thank you for your lovely introductions and support. I have had the pleasure of scrolling through slides a few times in my life. Hi, all. I'm Jonas Farnham from Health Catalyst. Thank you for the introduction. And we can talk a little bit as we work on some technology, right? So I'll just go ahead and get started, and we'll all be paying attention to me as opposed to what's happening on the screen to my right. But thanks so much, guys. So today we're talking about data-driven health outcomes. That was actually the fastest I've ever seen IT support work, so good job. So data-driven health outcomes with a framework for sustainable success. And as we were focusing in on kind of what do we collectively want to talk about today, it really was using data effectively, using data to identify and then deliver on opportunities and outcomes, on knowledge and insights for patients. But it's been a while since we actually started thinking about how we got here, why we're here. And there's a reason why I want to start here is because how many of you work with DSRIP funding or DSRIP models? Great. So I think I saw every single hand. No, but a lot of people here today are thinking in terms of money that has, some conversations right now within various legislatures, whether that's federal or state here at New York, about, hey, what's funding look like in a few years, right? That's been an ongoing conversation with DSRIP. And I generally, when we start thinking about pop health and then all this data conversation, it actually starts with the problem is still financial. And the problem's quality and clinical as well. But we, 2012, 2010, even before that, plenty before that, we started hearing about $1 in every $5 in our wallet, $1 in every $6 in our wallet goes to healthcare services and healthcare as opposed to health and taking care of us upstream. And so we're just spending money over and over again. Our employers are spending money over and over again. Our states are really losing the battle that they have to actually use the money in their budgets to care for and to provide that money upstream for education, for some of the components of the social determinants of health that we'll talk about later that can be scaled across a statewide level are actually being spent on just taking care of patients when they hit Albany Medical Center and some of our inpatient services. So our challenge continues to be that we have a rising healthcare spend, and we've had this over time. I'm not going to go through history, but I am going to focus on, over the last 10 years, we've started really thinking about a wave of what is called clinical integration. Different delivery models that at the center of it is clinical integration. And we had the precursors of these in the 1990s with HMOs, but there was also this group out in Grand Junction and in Arizona that started coming together and thinking about healthcare without silos and really saying, I want to share information from a financial perspective, and I want to share information from a clinical perspective. That's Grand Mesa IPA, Rochester, another one of the greater Rochester IPAs. That was the beginnings of clinical integration as we know it currently. And so everybody started and said, we have to let data be the center of how we're integrated. Because when we use data effectively and we know more information, we actually know that less intervention provides better outcomes. And so this this issue about money and our current problem has led to clinical integration at the center, with data at the center. And today we have over 1,000 accountable care organizations across the nation. We have even much more types of delivery models, whether it's a community health organization type model. And the reason why there's such a proliferation is because healthcare remains local. And that'll be a theme that I'll reference plenty today. But there's been a question about whether our work is successful. And this has been a newer question because people are starting to ask, should we continue to fund and support these types of organizations? And man, that's scary. But but we are. I mean, I think the jury's still out, and there's a lot of people that want to frame data. I've never seen a federal government decide that they want to, make a spin on something, right? But there's current governance analysis, there's current kind of organizations that have stopped and said, we have data that can really show health outcomes are improving, costs are improving, quality's improving, and when costs improving, that really means that the dollars are going down. And I am focusing right now on the Medicare Shared Savings Program, and I know a lot of these people in here are Medicaid focused, but there's a reason why we have to always watch what's going on with Medicare, and particularly the MSSP, and that's because it is baked into the Affordable Care Act. This isn't something that we can just turn off. So unless the federal government says goodbye Affordable Care Act, which, I never thought that would happen. But but it is not something that the director of HHS or CMMI or any other government can just say by executive mandate, we want to turn off. It is something that will be in the conversation. And so I give that background by saying there's going to continue to be these delivery models. This conversation about, hey, our healthcare costs are rising. There's this proliferation of different delivery models out there right now nationally and locally. Healthcare is local. And that there's good evidence that we're succeeding, even though there might be some people that aren't ready to just get on the bandwagon yet. That's a great story right now for us. We are in phase 1 or phase 2. So I think when we have a sustainable health system that really says we're at value, that might look like phase 4 or phase 5 of our journeys. And I think we're still in the early infancy phases, even though there's been a lot of movement here over the last 10 years. But we're doing well. We're being successful. And at the core of this success are two things. One is kind of capabilities and skills, and the other is process. So how do we actually make outcomes identifiable for our patient populations? And then how do we actually move the needle and impact patients one-on-one within our communities? Skills and capabilities and process. How many of you have all heard of a book called The Checklist Manifesto? Yeah. Came out in 2009 by a very prominent physician out of, that I can't think of the name of right now. When he worked at Togawande, thank you. He works at Partners with some of my colleagues, but and he did this study called the Checklist Manifesto, and he really came out with Johns Hopkins and said, we can, if we do these 10 things, and wrote them down on a checklist, we can really reduce actual inpatient causes of harm, essentially. And this just continued to be a theme that he hounded. He was in residency at the time. And it's a process that works. And I come back to capabilities, skills, and process, because if we do these things at a checklist level every day, we go up and we say we're making sure that we have the founding attributes that are right here and the process that I'll show on the next slide. That's how we're successful in population health over and over and over again. This is local, And this is a capabilities to scale outcomes improvement. This is local. This actually translates all the way up to some of our biggest organizations across the nation. This actually is a culmination of work from Intermountain Healthcare with Dr. Brent James, who's done a lot of work on clinical variation reduction, some of the work in partners that's going on now, and then also some best practices. And what you're thinking about is, how do we scale outcomes improvement? You need three things at the core. The first is, what should we be doing, and do we have knowledge that that's correct? What's scary right now is that's often the answer is no. 25% of our cardiovascular best practices have inherent evidence behind them, which means 75% are physicians have some evidence that what they're going to do at for cardiovascular interventions is correct. Sometimes they don't. Sometimes they're trained. That's scary. But we have to know what is the best practice, where is there gaps, when do we not have information, and that drives what should we be doing. We have to make it easier. We have to have information that allows Dr. Water-Rietzema and everybody else. My wife's a physician. I work with a lot of clinicians. We have to give them information that makes this just easier. And that's analytics. How do we actually interact with our clinical teams to provide you this best practice? How do we make this easy for you to care? How do we give our care managers and our behavioral health specialists information that says, this is when you should do motivational interviewing. This is maybe when you shouldn't. Make it easy. And lastly, adoption. Is this going to be something that we can do on a regular, scalable basis? And those things, when they come together, that's when we drive outcomes. And if we do that within a consistent checklist approach, that's when we'll be successful. But what's around that, I started this conversation with, right? Financial issues, financial alignment, and then leadership, culture, and governance. And this is the biggest challenge that there is, in my opinion, and please disagree with me, but the amount of times that we work with large-scale organizations that will say, oh, we know what we're doing, and I've got this Medicaid program, and I've got best practices for our Medicaid program. I've got our physician champion. He knows what he's doing. He's telling everybody this is how you take care of behavioral health. And finally I say, okay, this is great. Tell me about your accountable care organization that's your partner organization that has a lot of individuals out in the community. And they'll say, oh, they don't want to talk to us. And that doesn't work either. So leadership, culture, and governance, and really collaborating across organizations and thinking through, this is a large-scale problem that we need to understand how to scale this, how to understand where there's silos, where there's abilities to interact and engage. These all work both locally, nationally, and I'm sure you all might be touched by it. So, what's the process? If one is skills and capabilities, and two becomes process. So having these conversations of really figuring out, again, let's use data to identify and deliver on opportunities and outcomes. I think the things that we really see is we need to make people walk through a systematic way to gather the right data, use that, put that into adoption, again, give them the skills they need to actually use the data effectively, and that will change the culture. And so the process really starts from data. It starts at the data layer. Let's ask the questions, do you have the right data? Do you know why you need that data? How do you want to use this data? And then how should this data come into a system so that it can be exported effectively currently and exported effectively and used effectively a year from now and potentially 2 years from now. It's really unhelpful when Medicaid gives you data information and we store it in one way, and then next year they ask us for the data and we've saved over a previous year's of data, and all of a sudden we're missing kind of encounter information. Oh, good idea. I forgot to do that too. So the first is storing data, understanding where the data is. The second part is, okay, I have stored the data. From a process perspective, I need to understand what it's telling me. I need to have this data transformed analytically and see the best practices and see what I should be doing when and where are there opportunities. Which patients, which physicians, which community members can impact this story that the data is telling me. Mark gave a great example of connecting data for benchmarking on hypertension and diabetes prevalence. Another good example is, can we connect social determinants of health and patient self-reported data with claims and clinical data? But the question is, well, is there an appropriate use for all of those data elements to come together? And the answer is yes, sometimes, but not every time. I worked with Christiana Care in Delaware, that's kind of close regionally here. And we had a very kind of heavy conversation about connecting claims and clinical data to reduce unnecessary admissions. So not even readmissions, just which admissions shouldn't go to the hospital. And we found out through a lot of research and time and energy, we actually only needed claims data to deal with that algorithm. The clinical elements that we included weren't as helpful as just looking at claims data. And within some of that claims data is a little tiny bit of social information, but that's baked into the claims data. So it really, all we need for a maturation, for a mature data science algorithm on that, to understand our opportunities, was claims data. And once we understand those opportunities, that's when we intervene. That's when we tactically say, okay, behavioral health specialist, we're going to have some clinical transformation opportunities within this particular patient population, or financial opportunities. You know, the disease prevalence conversation could come back to, are we coding hypertension better and differently than our national counterparts? Have we had that opportunity to make sure that all of the levers we're pulling, including coding, are accurate, and our payers are impacting us for that difficult work? So this process is cyclical, and these two steps are really, if you do these over and over again, this is what we've seen really makes outcomes identifiable, and then you can actually go attack them. It's not a one-size-fits-all. So healthcare is local, and I would suggest that this audience doesn't need a giant, all the time, this gigantic system that says, I need to understand every single element, I need to store it properly, I need tools inside of that to make sure the HL7 feeds it, blah, blah, blah. You guys have stopped listening, because that's really too technical for all of our needs. We do need to make sure we're storing silos correctly. We need to make sure that as the data comes in, it's structured in a manner that fits your organization, that fits your need, and that we can reuse that quickly. You shouldn't have to spend a lot of time and energy going back and digging through data. And then once we've stored that data, and again, this should be claims and clinical, and we've heard a little bit about this from Mark, that's when we sit back and we say, I need to understand this use case, and I need to do it quickly and rapidly to see if I have an opportunity. Listen to your clinicians, listen to your stakeholders, and when you are listening and you're surveying, I've done 2 surveys here already today on Checklist Manifesto and DISREP, put that into data. My surveys were really bad quality, right? Bad data in, bad data out, but put that qualitative information into your data repository here on the far side, and that helps you with your data decision. Going back to your skills and capabilities. So one approach then to actually understanding how to get best practices and your checklist manifesto as create your charter, create your scope. We've done this regularly, and we really very infrequently start a project where we haven't had a very clear understanding of what data sources are coming in, who's using them and why, what the end goal is, who's accountable. And that really helps you understand if this is going to be a provider-focused data opportunity, where I'm going to sit back and I'm going to give a provider report card, and it's going to have how many patients are going to which types of long-term care facilities. And these are my data elements that really give me a level of accuracy about the information I'm about to receive. And you want to really understand the depth of the data. First, just get the highlight nuggets where you've got a prevalence of hypertension at X, but then you're going to start thinking about, am I coding that correctly? Are my measures up to HEDIS standards, which is a challenge? What do I really need to think about everything within that particular measure? And so that cadence kind of expands. And then last, if you do all these things, this is what we've found really drives opportunities and outcomes. And I picked a disrep type of initiative here. This is within Texas. And I know that Health Catalyst has worked with some of the organizations in here today and some of the PPSs to do similar work here. And thank you for that opportunity. But when you identify that data and you store it really quickly and accurately at a broad scale, you can really show your value and proliferate that. And I think we'll get into a little bit more of how do we show value and really communicate that here soon. But that's really important, is as we identify outcomes and we actually intervene and make successes, you also need that data stored properly so you can communicate back to various stakeholders about how you're doing, how you're improving. So with DISREP, there was improvement in 23 of 32 measures. That's good. That's great. I personally want to hear the story, and I did hear the story of the other 9, and we want to know what's going on there. But we need to celebrate that 72%, and that does give us $2.1 million in cost reductions. So that's a really great story that we can go communicate, and UTMB is communicating with a lot of their stakeholders as they think about scaling their successes. So with that, I think I'm going to turn it over to Erica. Jacob, questions at the end?
Yeah.
Great. Thanks, guys. Erica.
Thanks. I just have to switch my slides.
I think they're going to be continuous. I hope.
Yes, great. Thank you. Oh, they're here. Thank you. Hi, everyone. I'm Erica Wal-Ward. I work for the Psyches team at the New York State Office of Mental Health, and I'm really honored to be here today. And I think you'll see why, for my presentation, we chose this order. Jacob was talking about a lot of really important things to set the stage for what I'm going to share with you in Psyches. I'm just going to really quickly do a Psyches overview for any colleagues in the audience that haven't used Psyches yet. So it's an online application that's secure and HIPAA compliant. You get access to the organization that you work with, and I'll talk a little bit about that at the end. But essentially, most of our data is from Medicaid billing, so claims and encounters from fee-for-service and managed care. And we take that data and present it in different ways, in client-level reports to help with clinical decision-making and care coordination, in population health reports and recipient search, so you can run cohorts of interest and get a report, get a count, and quality indicator reports. We have a lot of different quality measures, some that are based on HEDIS and QAR, and you can look at prevalence rates for your agency and compare that to other provider agencies in your area and in the region and the state. So we really show really anything that comes in through Medicaid billing and other state administrative databases too. So we're always looking for new data and new data sources to pull in and show in Psyches in different ways. So the population that we have in Psyches is the behavioral health population. So it's New York State Medicaid enrollees who are in the behavioral health population, meaning they've had a mental health or substance use service, a mental health or substance use diagnosis, or any psychotropic medication billed to Medicaid. If they have one of those three things, they're in our population, which represents about half of the state Medicaid population. But then once they're in our system, once they're in our Psyches application, the information that we display about those individuals is information across the treatment spectrum, so medical and mental health and substance use information with client consent. And so that's medications picked up at the pharmacy, mental health and medical outpatient and inpatient services, health home information, managed care plan information, labs, radiology, and so on. So a lot of data shown to you in different ways. Quality flags and alerts. So we have quality measures and quality indicators and quality flags that helps you identify opportunities for improvement or identify clients of concern. And so some examples of that. So we have quality flags like no diabetes, folks who have not had their diabetes screening or monitoring if they already have diabetes or if they are on an antipsychotic medication. We have flags around that. We have quality measures and flags around medication adherence. So for individuals that have schizophrenia, maybe started a regimen of an antipsychotic medication but didn't remain on that medication for 80% of their treatment period. There's a flag about that. And we have measures around hospital utilization. So flags to identify clients that have been in the hospital 2 or more times in the past year for either inpatient or ER visits in the past year, and a hospital readmission flag to identify clients who were discharged from a hospital and readmitted within 30 days. So those are some of our quality measures. And we also have alerts to help you identify high-risk cohorts that you're caring for. So people who have had a suicide attempt ever, or recently, people who have had suicidal ideation or self-harm or self-poisoning. We have opioid overdose alerts in Psyches now, and coming in October, we'll have an overdose risk alert coming to identify individuals who are on both an opioid and a benzodiazepine. So we're always trying to add more measures and add more alerts to help you do your work. So I'm going to talk about 2 areas in the Psyches application. First, I'm going to talk about how to use data in Psyches if you're going to do a value proposition with a payer. So if you're preparing for a meeting with a payer like a plan or an ACO, you're doing a pitch or a value proposition, and you want to prepare data for that meeting, I'm going to show you how Psyches can be a tool to help you do that. And then I'm going to show you a clinical summary and our brand new brief clinical summary to show you how Psyches can be used for client-level care, for clinical decision-making and treatment planning. And then at the end, I'm just going to talk about access, how to get access to Psyches, who's eligible now, where are we expanding in the future, and how do you get training and technical support. So first, using Psyches to demonstrate value. So we're going to look at 2 reports in Psyches for how to do this. We're going to look at My QI report and recipient search. In My QI report, I'm going to show you an example of how you can show your agency is successful in a particular quality measure compared to others in your region and state to help you tell your story, or use data to back up your story and connect the dots from the work that you do every day, if you're a provider organization, to what the data is showing down the line. And in QI reports, you can filter your reports in different ways, by a particular program setting, by clients you serve who are enrolled in a particular managed care plan, and so on. And then we're going to look at recipient search. Recipient search, you can do all kinds of things. Plug in some filters, click search, and get a list and a count of people who meet a certain criteria. So we're going to look at how you can show the number of clients you serve who meet a certain criteria, and how that can be an opportunity for improvement when you're meeting with that payer. So let's start with QI report. So here's a screenshot of my QI report from earlier this year. And we have a list of all of our different quality indicator sets. So when you log in, this data is already there for you. You don't have to put any data in here because it's from the billing information. So it's automatically in here, and we refresh these every month. And so let's pretend that I'm Main Street Mental Health Center. I'm preparing for a meeting with a payer. And I do want to recognize and point out, I've learned that networking is really important too. So if these could be small numbers in some cases, so networking in that case is good. But so let's say we're preparing for a meeting with a payer, and we want to show how we're, like my organization, Main Street Mental Health, we're rock stars in engagement maybe. Maybe that's my story, that I'm really good, like we welcome our clients really well at the door. I know everybody by their name. They love coming here. And I'm really strong in X, Y, and Z. That's the story that I want to tell. But what's the downstream impact that payer might care about? So let's pretend that they care about hospital utilization, keeping people out of the hospital, low hospitalization rates. So a low prevalence rate in Psyches is showing how you're doing pretty good in a certain area maybe. And so Main Street Mental Health, my prevalence rate, according to my QI report, that for high utilization, that prevalence rate is lower than my competitors. My region, other providers in my region, and the statewide prevalence rate. So in that meeting, you could use this data to tell your story, but also connect the dots to something that payer might care about, hypothetically speaking. But this is how you can show, I'm really strong in this area. You can also filter my QI report, especially if you have a lot of different programs and you just want to talk about one program, like your clinic or your care management program. You can go to the filters button in my QI report and put on a specific program type like clinic. You could also filter for clients you serve who are enrolled in a specific managed care plan. So you could go managed care plan, put on that filter, and now your numbers show, okay, for this specific managed care plan who you're meeting with, my prevalence rate is still low and even lower still compared to the region and the state. And these are your enrollees plan, so let's work together. There's another thing you could do in my QI report that I just want to make sure everyone knows about. We have this tab. Once you drill into the quality measure that you're interested in, or better still, the payer that you're about to meet with, what they care about, drill into that measure, go to this MCO tab. So this might be a way to identify plans that a lot of the clients you're serving are enrolled in. So MCO tab in my QI report breaks out your numbers by plan. These are plans that your clients are enrolled in. Okay, next, I'm going to show you recipient search. So this is zoomed in a little bit on recipient search, and you'll get here by clicking on that recipient search tab along the navigation links along the top in Psyches. So in recipient search, you can put in almost any parameter you want. Hit the search button, and what the recipient search will give you is a count, the number of people you've served in the past year who meet the search criteria, and a list of who those people are. So now this is my opportunity to show volume, to show opportunities for impact. So let's say I'm meeting with a payer who really cares about diabetes care. And maybe even part of that, people who have schizophrenia and diabetes. So what I can show, I can use Psyches to show, I serve a lot of people that have diabetes maybe. So let's go to the medical diagnosis section of recipient search. Under the metabolic and endocrine diseases section, you'll find type 1 and type 2 diabetes. Click search. Okay, I have over 1,000 people I've served in the past year that have diabetes. So that could be a large number. And of that, go back, put on another filter. You can layer other filters on in recipient search to really drill into what you want. So of that, 410 of those people with diabetes also have schizophrenia. So if that's, so use that to show the opportunity for impact, and then tell your story about how you're caring for them, whether it's screening, certain interventions, coordination of care, getting their labs. Okay, so that is for using Psyches to demonstrate value. Next, I just wanted to quickly show you the Psyches clinical summary. So the clinical summary you can get to by looking up a client through recipient search, through Medicaid ID, their name or date of birth. Best way to do this is to get a client's consent at the front door with other paperwork they might be signing, obtain their consent, so you can get full access to a client's clinical summary that you're seeing. So this is a snapshot of our brand new brief overview of the clinical summary. So for those of you who already use Psyches and you've seen the clinical summary before, you know it can get quite lengthy when you're looking at the 5-year view. There's a lot of sections in there, a lot of information. The brief overview tries to pull out the most clinically relevant information in 1 to 2 pages. We did some focus groups to figure out what is the most relevant information, but in a nutshell, clinical summary is going to show you, is this person in a health home? What health home are they in? What's the care management organization? We pull from the DOH map system to know who that is, and we update that weekly. Are they in a HARP? Have they had their HCBS assessment? Next is alerts and incidents. So has this client had any suicide attempts, opioid overdoses? So this particular client, and this is all different parts of different clinical summaries. This isn't just one person's record, but so alerts and incidents. So this particular person had 4 suicidal attempts and an opioid overdose. Then you're going to see quality flags. So is this person that I'm serving meeting any criteria for quality flags? So this particular individual has high hospital utilization, so that might be something I want to pay attention to. They also had a substance use, alcohol or other drug diagnosis, and no treatment engagement for that in the past year. I'll see their diagnoses, both behavioral health and medical diagnoses, medications that they picked up at the pharmacy, outpatient services, and hospital utilization organized in emergency room visits and inpatient visits. And we update the clinical summary every week. Next, I wanted to talk about access to Psyches. So the first list is organizations that are eligible for Psyches access right now. We've expanded a lot over the past 10 years. We just started with some clinics participating in our project, but we've broadened access to Psyches a lot. So it's behavioral health agencies that have just one program with an OMH license or an OASAS license. Some HCBS programs, Department of Health, health homes and care management agencies, hospitals, FQHCs, LGUs, and the plans, the Medicaid plans use Psyches. We're going to be expanding next to freestanding medical agencies like primary care. We have a special type of Psyches access that is just launching in October, that everything is consent-based. There's no quality flag level of access, like for our mental health programs, there's some quality flag level of access with the medical clinics. Everything is with consent. And agencies licensed by OPWDD will be another future expansion. So those last 2 on the list are future expansions. So this information is on your handout in your folder, how to get access to Psyches. If your organization already has access, you just need your security manager to grant you access, OMH user ID, and a token to log in. You can contact us at Psyches Help for assistance with that. But if your organization doesn't have access yet and you're not sure if you're eligible or not, just contact us at Psyches Help. But essentially, there's some paperwork you'll fill out, and we'll walk you through the process. One thing I was asked to mention is about HCBS, or home and community-based services, have 2 types of Psyches access. And someone earlier asked about like a limited data set for certain organizations that might not need clinical data. Like you might not need to know someone's diagnosis or their medications, but you might want to know what health home are they in and are they eligible for HARP HCBS. That might be important to know. So if you are an HCBS organization that provides CPST or intensive crisis respite, you're eligible for regular Psyches access like any other behavioral health provider. But if you have any other type of HCBS program, like education support, family support, habilitation, the transition employment, peer support, psychosocial rehab, there's a special type of Psyches access for you. And it's really just care coordination information and managed care plan and HARP information. So it's a limited Psyches access with client consent only. And finally, you can access training through our website. We have lots of different webinars. You can come to a live webinar or view a recorded webinar. And we have user guides that we keep up to date through our website. And contact us. Here's our email address, also in your Psyches handout in the folder. Contact us at Psyches Help if you have any questions about Psyches. And if you need any help with your token, I provided on your handout the Health Help desk. Thank you so much.
Good morning, everyone. Can you hear me okay? Yes. So I might get in trouble for this, but John Paul and I are sharing this presentation, so I'm going to stay here so we can work back and forth. So our goals for today are to tell you a little bit about the Unite Us platform in case you haven't heard about it before, to talk about how we see ourselves fitting into this transition towards value-based payment, and then give you a few examples of how some of our networks have used social care data to demonstrate value to payers. So many of you in the room have probably already heard the origin story before, but for those of you that haven't, Unite Us was actually created by two veterans who, when they returned from active duty, were really struggling to connect themselves and their fellow vets to the clinical and social services that were available to them. They found there to be a lot of siloing and lack of coordination existing in the social service and clinical landscape. So they launched Unite Us originally as a platform for the military and veteran community, and very quickly realized that the siloing and lack of coordination that existed is not unique to the military and veteran community. And so they've since expanded. Unite Us is now across the country with a specific focus on addressing the social determinants of health for all populations. Essentially, what Unite Us is an online HIPAA-compliant platform where clinical and social service providers can send what we call closed-loop referrals for clinical and social services and improve the communication and coordination of care that exists for those clients and patients that they are sharing together. So the goal of Unite Us is really not to reinvent the wheel entirely and replace the existing social and clinical services that are being provided in your communities. We're not trying to replace the relationships and the knowledge that you have of those communities. We're just trying to make it easier for clinical and social service providers to do what they're already doing by breaking down those silos and improving communication and coordination so that ultimately we can be serving more patients and better leveraging our resources. One of the foundational sort of beliefs of Unite Us is that the old way of doing things, in which patients are repeatedly returning to the clinical environment to have their social care needs met, is not working. And we also believe that social care services are imperative to patient health, and that clinical providers really need the services that social care agencies are offering to keep a patient healthy. But up until now, clinical providers haven't necessarily had a way to see what social services their clients are receiving and what's happening to them when they leave the clinical environment. So that's really the problem that Unite Us is hoping to address through this platform. So this is sort of the theme of the day, so nothing new for anyone in the room, but we see ourselves fitting into this current transition from fee-for-service to managed care. So as you know, we're shifting from paying for service by service to paying for patients for their care. But even within that transition, many times providers are still paid on a fee-for-service basis, so there's not necessarily always an incentive to address the social determinants of health or to improve cost or reduce costs, I should say. And so this transition towards value-based payment is really where we can start to address social determinants of health and focus on outcomes and reducing costs. And that's a really key place where we see social care providers fitting into this important work of transitioning to value. So how does Unite Us fit into that? Within the Unite Us platform, any partner organization who is participating has access to individual level data on the clinical or social care services that are being provided. So you have access to the types of services that are being requested, as well as the outcomes of those service requests. So was the patient's need met? Were they able to get housing? Were they able to get food assistance? Were they able to have assistance enrolling in Medicaid or job training skills so that they can become employed? So all of these things are available on an individual level for any organization that is using the Unite Us platform. On a network level, partner organizations also have access to aggregate data on the community that's being served. So you can see demographic information for the population, as well as, on the whole, the types of services that are being requested, as well as gaps in services. So you can start to identify where additional resources are needed. So both of these types of data, the individual level data on social care services being provided, as well as aggregate data on community level need, can be useful to demonstrating value for the work that's already being done and for targeting future funding and investment opportunities. Okay, so a few examples of how some of the Unite Us networks have used social care data that's available through the Unite Us platform to demonstrate value. So one of our networks in New York City that is focused on providing food assistance looked at existing research on SNAP and medically tailored meals and the estimates of cost savings to Medicaid. And based on the population that they were serving and the services that were being provided, they estimated an annual cost savings of $320,000 to the Medicaid program. So yes, this is an estimate. It's based on the social care data from Unite Us about the services they were providing and existing research. But we really see this as a jumping off point for those of you who are already providing social services to begin to demonstrate the value of the work that you're doing from a payer perspective. I'm going to pass it to John Paul to talk about another example.
Sure. Looks like we're missing some pictures.
I think it's
Is it
animated.
Oh, gotcha. Oh, there we go. Cool. So before joining Unite Us, I was humbled, honestly, to be VP of a relatively large nonprofit in Rochester, New York, and I was tasked with the insane challenge of how do we tackle the issue of poverty in Rochester, New York. Something that I'm sure you guys talk about here in your own community, but in Rochester, New York, if you don't know, we've experienced a tremendous, just an extreme rate of poverty in the last 10 to 20 years. We have the highest rate of childhood poverty in the country for a city our size. As you know, we've lost a lot of our, what we used to call the big three. 10 to 20 years ago, even 30 years ago, if you told us who the biggest employers in Rochester, New York were, it was Xerox, it was Kodak, it was Bausch & Lomb. Now the largest employer is the hospital system. So think about, just chew on that for a little bit. Jacob so well articulated very eloquently today that we live in a world where we're incentivizing sick care rather than health care, right? And think about what's happening in Rochester where the employers have gone away, families are getting poorer, people are getting sicker, and who's the largest employer? The people taking care of the sick, poor people, right? How sad is that? So we were really faced with this challenge of how do we address people's social determinants of health? How do we make them more economically mobile? We understood that particularly economic mobility and having a stable job was probably one of the biggest pillars to the social determinants of health, making people successful. So we centered on two interventions. The first was something that came out of Boston, Massachusetts, called mobility mentoring. This was a model that really takes like a life coach, assigns families and individuals a life coach. They meet at a weekly cadence. They look at the individual from a holistic perspective in terms of what are your resources and assets in terms of childcare, transportation? What are your relationships like with your friends? What sort of opportunities do you have to go back to school or to get your GED? How stable are you in terms of your behavioral health? And we really looked at the individual holistically. What we realized right off the bat, like within a couple months of running this program, is holy cow, we can't do this on our own. The best mentor, the best program, the best intervention can't do this on its own. We really needed to leverage the community-based organizations around us. We needed to view the patient holistically. We need to have visibility in terms of what was happening in their lives, and we needed to have an infrastructure and a data ecosystem that can give us the right data at the right time so we can red flag things, make interventions, because everything in life, as you know, you don't just like project manage someone's life and think it's all gonna work. There's continual quality improvement. We're complex human beings, right? And so we really needed to leverage something. At first, we started using what we all use, spreadsheets, right? We'll call each other up, we'll try to email and do secure stuff, and that was almost impossible to manage and control. So I met this strange company at a conference. They were called Unite Us, and I thought they were amazing in terms of what they did, so we gave it a stab. So in Rochester, New York, we started with about 12 to 15 programs. We developed the 360 network in Rochester, New York. We started working with the University of Notre Dame. We actually used a control study. We are almost done with a 2-year study in terms of the success of how it is that we can get people to be both economically stable, but bring them up to economic mobility and move them out of poverty, hopefully. And we leveraged Unite Us technology. We started connecting. Right now, that network probably has a little over 50 community-based organizations that are engaged. And so what were the results? The results so far, a little after a year, we were able to go from an employment rate of 29%. We almost doubled the employment rate in our population. We more than doubled the average household income, and so that was great success for us. Our lesson learned there, again, is that we can't do this on our own. As CBOs, we often, we'll go out there and say we're the best at everything, and we are at a lot of things, but we obviously need each other to do this work effectively, and I would argue that's the case in everything. As we've learned, the social determinants of health are also the social determinants of employment, are also the social determinants of education, are ultimately the social determinants of self-sufficiency. So.
Thank you. So in addition to those examples, there's a number of additional projects underway to use social care data and other data sources to demonstrate value for payers. So one example would be our CVS Health and Centene networks, who will be using patient demographic information from Unite Us about the social services being provided and the outcomes of those services, as well as healthcare claims data to measure impact on ED utilization, total cost of care, and hospital readmission. And then they'll be using that research to further target future investment and funding opportunities for the communities that they work in so that they can better focus their resources on community need. The Healthy Alliance IPA, which is being championed by Alliance for Better Health, is focusing on a variety of different populations and service types, but they're contracting with local managed care organizations and will be using Unite Us data along with other social service data and healthcare data to measure outcomes for the populations they're working with and pay the social care providers who are providing those services from the managed care organizations. And then finally, the North Carolina Department of Health and Human Services has a Section 1115 waiver for a 5-year pilot program that is also meant to pay social care providers, and they will also be using their Unite Us platform to track the provision of those social services as well as the outcomes to pay the social care providers who are part of that pilot program for those services. So super exciting stuff underway, and I think on the whole, we see this upward trajectory. We're somewhere between phase 0 and 30 right now, closer to the 0 end of things, but nobody's really counting. So we talked about this evolution from payers buying for services to buying for outcomes, and we can't start doing that work until we're better coordinating care and measuring what we're providing to patients. And once we do that, once we better connect community services and measure that work, that's when we can really start to innovate and start to focus on those value-based payment propositions. So once those value-based payment models are in place and funding sources are more sustainable for community and social service providers, that's when we can start to standardize those payments and make them sort of matter of course for social care services, And from there, that's when we really influence policy and start to affect systematic change. So that's really where we see the shift and moving the needle on a systematic level to address social determinants of health. That's where we start to impact those generational cycles of poverty and poor health that folks in the room have been working their entire careers to address. So we're super excited about this. We feel like there's so much work to be done, and all of you in the room are the ones who are going to be doing it with us. So we're amped to do it with you.
Hello, I am Tavia Rauch, and I'm the Director of Strategic Initiatives at Hixny, and I'm here today to talk a little bit about data quality. Data quality at Hixny reminded me a lot about that season that I coached kindergarten soccer. I was really excited. I went onto YouTube and I learned a bunch of plays. I got a clipboard and a pair of new sneakers, and I hit that field thinking that I was going to teach these kids how to score goals. As soon as I got there, I quickly looked around, and I had one little kid who was rolling around on the field because he was a caterpillar. 2 kids thought they were playing football. 3 of them had to go to the bathroom, and I literally had a little boy sitting there eating handfuls of grass. I realized very quickly we're not scoring goals. My job was to just get everybody on the field and maybe teach them a little bit about teamwork. Data quality at Hixny was a lot like that for me when I took it over. I was so excited. I thought that I was going to make such big changes really quickly and add a lot of benefit to our community. And then I started looking at the data. We have over 36 EHR vendors that send us data, and a lot of those vendors have different levels or different models of their health record, and everyone's sending us data in a different way. I wasn't going to be able to make huge sweeping changes. I had to take a step back, and I had to learn a lot about our region's data. What was the quality? How are people sending it? And then maybe come up with a plan to make a small change. So what is data quality? I'm talking about it, but what is it? Well, it's really simple. Data quality is just the state of information, and high quality data can be applied to achieve an outcome. If you start at the bottom of the pyramid with data that has good quality, it means that someone can put those pieces together to create information. And if you use your information to inform a decision maker, then you're really arming them with knowledge. And good quality data in the right hands, it actually can give someone the wisdom to impact our outcomes. And that's what we're all here for, right? Learning how to impact health outcomes. So Mark talked about the different types of data. Well, clinical data is one of them. And I look around and I see a lot of people that I know in this audience. And I know that most of you, your primary data source that you have is clinical data. And clinical data lives in your electronic health record. Everything that you input into your record is actually your data. There are some examples up on the screen. You have diagnoses. So a diagnosis of diabetes or schizophrenia is part of your data. You could have vital signs. If you take someone's weight or height and put that in an electronic medical record, it's data. Assessments. If you're doing an assessment, whether it's a depression screening or maybe a nicotine dependence assessment, that's also part of your data. All of the data in an EHR is really connected to something in the background. When you select that diagnosis from that dropdown, or when you input a height or weight into a specific field, something is happening behind the scenes. Your EHR is actually storing that data for you. most often, it's stored in something called a table, and it's stored as a code, a numeric or alphanumeric group of numbers. The code is actually what you need to pull that data out of your EHR and to get you credit for the care that you're giving. Everybody's doing the right thing. I know that. I see it every day, but you want to get credit for that. There are more advanced ways of pulling data out of an EHR. There's natural language processing, text strings, there's a lot of things like that. But the most common practice is code-based extraction. If your EHR is not treating your data correctly, you're going to have troubles getting it out, and you're not going to be able to apply it to that desired outcome. So what makes this data interoperable? How are you going to get it out, and how are you going to send it places? Well, there's a standard code for data that's in an EHR. That first thing on the list is a diagnosis. And one of the standard national standards for diagnosis codes is ICD-10. I bet most people in here are familiar with ICD-10 or have at least heard it. Why? Because you use those codes for billing and reimbursement. Some of your EHRs in the background, as I'm talking about things are being stored in these tables, some EHRs, as soon as the doctor puts the diagnosis in or the provider puts it into the record, it can pull these codes out from the background, and sometimes they're submitted automatically to your payers. That only works if they're coded correctly and your vendor is treating your data right. If not, you might actually have to have someone that goes into the electronic health record, read what the doctor said, write down all the diagnosis, go to the standard ICD-10 codes, and then put them into your billing system for reimbursement. All data types in your EHR can and should have a nationally recognized standard code attached to them. So non-standard codes, what are non-standard codes? I'm talking all about these standards and how standard codes have to be attached to your data, but that's not always how it works. I listed some standard codes for mammograms. There is a LOINC, a SNOMED, and a CPT code. There's a lot more standard codes for mammograms than I've listed, but that's just a few. But what are non-standard codes? Well, at Hixny, we looked at, when I was looking over all of our data, I found codes that weren't standard, which means that when you're building an EHR, you can go in the background and you can really put whatever you want into those tables, and some people do that. One code up there is a mammo was performed 6/17/2017. Okay, and I looked and every patient had a different code because every patient had their mammograms done on a different date. There's one there, I can't quite see that, I think it's KDIGMDCBN. What does that have to do with a mammogram? I don't know. Then you have the 1, 2, 3, 4, 5, 3, 4, just a random sequence of numbers. My guess is maybe they started at 1, and everything in the EHR, they just kept 2, 3, 4, and now they're at about 1 million. And my personal favorite up there, mammo kills. Tend to agree. But when adding up all the codes that I've seen for mammograms, there are 624 codes in our region for mammograms. And how do I know that? So how do I know all these codes? How do I know mammo kills is actually a mammogram? Because I personally reviewed all of these codes for a separate project, and they're all attached to a radiological report for a mammogram. So I know that the patient went in, they were seen, the physician wrote the report, and they put the BI-RAD score in there, and this is how we're representing them. If you're working with an internal or an external analytics company, and you're just looking for those 3 standard codes to have mammograms, you put that in there and that's all you want to pull out, you're going to miss a lot of mammograms, which means your providers who are doing a good job and getting their patients screened aren't going to get credit for it, and that's going to have an impact on your quality measurement and your reimbursement. What do I have here? All right, so quality measurement, I was just talking about it. Breast cancer screening. There's a lot of programs that have a breast cancer screening measure. HEDIS, PCMH, There's a MIPS one, I think it's 112, ECQM. And what does that mean? Well, that means that calculating breast cancer screening prevalence is really valuable. At Hixny, we have a free interface that calculates a few of quality measures, and we do use all 624 of those codes to make sure you're getting credit for the care that you give. With the help of an engaged practice and all of our partners in this region, the PPSs have been very, very supportive of us and really helped us improve our data quality. We hope that we can increase the use of standard codes. And that's going to benefit not Hixny, but that's going to benefit everyone in this room. It will improve the mammogram capture rate, and that's going to be irrespective of who's calculating that quality measure for you. I mean, I loved the chaos that was kindergarten soccer, but I really look forward to reducing the chaos that is the quality of data in our region. But in the meantime, we will continue to do what we're doing so that we can accurately measure your practice's screening and prevalence rates. It's really important because you can't improve an outcome if you don't have a way to measure it. So this isn't really about Hixny. This is about everyone else in this room. It is your data and it's your call. But I encourage you to think about what data is important to you. What data is important to your organization's mission? Are you involved in any sort of quality improvement initiative? What about risk-based contracts? If you don't have good data quality, you're not going to have the confidence to enter into these contracts. But if you have good data quality, you're going to have something that you can tie to an outcome, and you're going to be able to do this moving forward. So do your research. Do you have to know the standard codes for every piece of data in your EHR? No. But understand that there are standard codes, and work with your vendors, your analytics vendors, your EHR vendors, to make sure that they're treating your data the way that you need them to so that you can improve your outcomes and you can be successful. We get to go to lunch soon, so.